said, welcome to this West Midlands region webinar on closed cultures. My name is Rachel Swain. I'm the Development Officer for Solihull Safeguarding Adults Board. And today we have Jon Ibbitson and Carl Gillson from CQC, who are going to talk to us about closed cultures. I'll let them introduce themselves in a little while, but just to say they're going to be doing sort of an introduction to closed cultures and helping us to think about what kind of things we might need to be aware of if we're encountering closed cultures. So this presentation has been arranged by Solihull Safeguarding Adults Board with support from Walsall Safeguarding Partnership. And a big thanks to Kellyanne Perry and Chloe Parish from Walsall for their support in organising this event. It's been organised to coincide with National Safeguarding Week, which is this week, and hopefully some of you have seen some of the material that Solihull Safeguarding Adult Board has been tweeting, and if you're from Solihull, you've hopefully seen the newsletter as well. I'm really pleased that there's at least 130 people on this webinar this afternoon from all across the West Midlands region and a variety of organisations, so that's fantastic. Welcome everyone. Just before I hand over to Jon and Carl, I'm just going to run through a couple of technicalities. So this webinar is being recorded, so we'll be sharing the link to the recording afterwards so that you can share with colleagues who weren't able to attend. And although we can't see or hear any of you during the webinar, you do have the opportunity to ask questions in the chat function. These questions will be collated and we'll be sending out responses to those along with the slides and the link to the webinar after the event. Okay, so we won't be providing responses today, but we will get those out to you after the event. At the end of the presentation, we'll be sharing a link in the chat function to an evaluation, and if you can complete that, we'd be really grateful. It's really helpful to get your feedback on these events. If you have any technical issues, you can put them in the chat. We'll do our best to help with those, but obviously they might relate to your own devices. Okay, I think I'm ready now to hand over to Jon and Carl.
Thank you. So firstly, we'd like to thank Solihull Safeguarding Adults Board, obviously, for inviting us to give this short presentation to you today on closed cultures as part of National Safeguarding Adults Week. Just to introduce myself, my name is Carl Gillson. I'm an Interim Inspection Manager working for the CQC in our Adult Social Care Directorate. I currently manage the Coventry and Solihull team, and I'll let my colleague Jon introduce himself.
Hello everyone, my name is Jon Ibbitson. I'm an Inspection Manager within Adult Social Care Directorate of CQC, and my team covers Staffordshire and Wolverhampton primarily.
Okay, so if we could have the next slide. Okay, so with the overall aim of raising awareness around closed cultures and their potential risk of harm that they carry to people who use services, the kind of broad topics that we will be covering as part of today's presentations is, what led to CQC's closed cultures work, what is a closed culture itself, what are the inherent risk factors that mean a service is more likely to develop a closed culture, what are the warning signs that suggest a closed culture is developing or has already developed within a service, and what should our response be in these circumstances? As the organisers have already explained, if you do have any questions as we go along, please use the chat facility to post these, and the organisers have kindly agreed to collate those and share them with us after the event so that we can respond to you in the coming few days. So if I can have the next slide. So we'd like to start our presentation today by talking briefly about the background to CQC's work around closed cultures and why we are engaged in this work. Further information about CQC's work around closed cultures, along with links to the new guidance published in June 2020 on identifying and responding to closed cultures, on which most of this presentation is based, can be found by following the link shown on the slide here to our website. So in terms of what led to CQC's closed cultures work, as we know, in May 2019, BBC Panorama exposed a shocking culture of abuse and human rights breaches of people with a learning disability and autistic people at Woolton Hall Independent Hospital in County Durham. This investigation reinforced the importance of everyone who is involved in the care of people with a learning disability or autistic people identifying closed cultures, and also brought home the difficulties we face in doing so, where there may be deliberate attempts by groups of staff to conceal these. As the independent regulator of health and social care in England, it also challenged CQC to fundamentally rethink how we regulated these services. Beyond this, we also know that closed cultures may lead to breaches of human rights, including abuse or significant harm across a wider range of health and social care settings, from GP practices to acute inpatient services to care homes. For this reason, identifying and responding to closed cultures is important for all aspects of CQC's regulatory work. Can I have the next slide? So adding to the importance of our ability to identify and respond to closed cultures effectively is the fact that during the current COVID-19 pandemic, there is an even greater likelihood that inherent risk factors of a closed culture will be present in more services, that closed cultures may develop in previously open services, and existing closed cultures may flourish. This is due to a combination of factors which include reduced external oversight. So more services are effectively operating as closed cultures or closed environments, due to a reduction in external oversight and scrutiny by family, friends, advocates, visiting health and social care professionals, commissioners, and CQC inspection teams. There are also reduced employment checks, changes made to the DBS check-in system to support the fight against coronavirus may increase the potential for unsuitable people to be employed in health and social care services who may ultimately want to harm people. Services are also under increased pressure. Services are having to cope with unprecedented pressures during the current pandemic, as, for example, they struggle to maintain safe staffing levels while some staff members are unable to work for COVID-related reasons. On a management front, services may have had regular changes in management or periods where the manager has not been on site due to sickness or the need to self-isolate, affecting, amongst other things, their ability to monitor and address staff working practices. Under these conditions, it is perhaps more important than ever that we identify where closed environments may develop into closed cultures. We as CQC inspection teams have to be mindful of the impact of COVID on closed cultures and also open to the possibility that any service, even those with a good regulatory history and without apparent inherent risk factors, could start to display warning signs of a closed culture. Could I have the next slide? So, as set out in the closed culture section page on our website, through our work around closed culture, CQC's overall aims are to improve our ability to hear from people who use services in closed cultures, to be able to give more weight to what they tell us and improve our ability to act on all of their concerns. And also for our inspectors to be able to effectively identify where there's a closed culture and be able to prioritise these services for monitoring and inspection on an ongoing basis. And to also to continue to embed human rights into the work that our inspection teams do. In addition, it's about improving our ability to collect and use intelligence to inform our understanding of risks associated with closed cultures. And finally, to use the information we gather through our inspection activity and elsewhere to work with and influence system partners to the changes that are outside of CQC's remit. Next slide, please. So if we consider, what we have done so far to improve regulation in the context of closed cultures work. So following the BBC Panorama programme on abuse at Wilton Hall last year, CQC commissioned 2 independent reviews by David Noble and Professor Glynis Murphy to look at how we could improve our regulation. Whilst awaiting the findings of these reviews, CQC took some practical steps designed to improve our regulation and ensure that all our inspection teams had a consistent and shared understanding of the risks associated with abusive cultures. This included producing initial supporting information, which you may have already seen, for our inspectors about how to identify and respond to closed cultures, which was published in November of last year and which was obviously made available on our website. In January 2020, the first independent review was published by David Noble, followed by the publication of Part 1 of Professor Glynis Murphy's independent review in March of this year. Both reviews made several recommendations, all of which CQC has accepted. In April of this year, we set up a dedicated closed cultures team to incorporate these recommendations into CQC policy and to work with external stakeholders, including people who use services, their families, and others to co-produce the changes we made. Since this time, CQC has released new guidance on closed cultures, as I've said earlier, for our inspection teams, which was published in June of this year, to support further improvement in how we identify and respond to these, which as I've said, has been published on our website. We have also trained approximately 2,000 inspectors on closed cultures over the course of this summer. Can I have the next slide? Just to continue the sort of discussion about what we've done so far in terms of the work completed around closed cultures. So CQC has refreshed our guidance on how we regulate providers supporting people with a learning disability and autistic people. This guidance, which you may have already come across, titled Right Support, Right Care, Right Culture, was published last month and replaces our previous guidance titled Registering the Right Support. While CQC's policy on how we regulate these providers remains the same, this new guidance is designed to be more accessible, clearer in terms of our expectations of providers, and is intended to improve consistency in our approach to regulating services supporting autistic people and/or those with a learning disability. In addition, CQC also published Out of Sight, Who Cares last month, the final report on our review of restraint, seclusion and segregation for autistic people and people with a learning disability and/or mental health condition. This report makes a number of recommendations for CQC and the wider system to improve care and outcomes for people with a learning disability and autistic people. Can I have the next slide? So in terms of what's next in relation to our closed cultures work, the first thing to say really is that CQC's work around closed cultures is ongoing, and it will shape our next strategy due to be published next year. And it will also inform how we work moving forward as a regulator. Over the coming year, CQC will continue to review our methodology and the tools and resources our inspectors use to strengthen these from a closed cultures perspective. Can I have the next slide? So to sort of get to the meat of our presentation, really, in this section of the presentation, we're going to focus on what a closed culture actually is. Perhaps as we do so, if you'd like to, you could post in the chat facility what comes into your mind when you hear the phrase closed culture. What kind of thoughts does that trigger for you as you can reflect on that phrase? So a closed culture can be described as a poor culture that can lead to harm, which can include human rights breaches such as abuse. And it's an important point to make that closed cultures can develop in any service that delivers care. For example, if we consider events at Winterbourne View, Mid Staffordshire Hospital and Wilton Hall, we can see that there have been public examples of abuse in hospital settings, including specialist, acute, community or independent hospitals. Equally, this type of abuse could occur where people receive care and support in their own homes or in residential care settings. Other settings that by their nature are more closed include healthcare services within criminal justice settings, and GP and dental practices are also vulnerable to developing closed cultures, as was shown by the crimes committed by Dr. Shipman and the elements of a closed culture identified in the practice where he worked. This slide that's currently on screen also lists some of the key features of a closed culture, which we'll come on to look at in more detail shortly. Just to expand a little on the first of the features listed there on screen, harm in a closed culture can be either deliberate or unintentional, and certainly we as inspection teams and perhaps as professionals more broadly need to be alert and prepared for both scenarios. We may automatically think harm to people is due to deliberate acts on the part of staff with malign intent, but this is clearly not always the case. Sometimes the reality is that staff involved in closed cultures don't see or have stopped seeing people's experiences. They no longer relate or have empathy or can no longer see those things. They may be following the poor example set for them by other staff. And due to management arrangements or weak management within a service, their working practices are not being effectively monitored or addressed by management. Where intentional harm does take place, it's likely to be concealed by groups of staff or even managers. Staff know what they're doing wrong in these circumstances and will often go to any length to hide this, unfortunately, making it all the more difficult for us to identify. Can I have the next slide? So CQC's updated guidance for inspection teams on identifying and responding to closed cultures, which I've referred to earlier and which was published in June and is readily available on our website, includes stories and quotes from people and their loved ones who've agreed to share these with us to better illustrate what the true impact of a closed culture is. This includes the following story from Amanda about her experience of a closed culture in a mental health setting, which I'll now give you a few moments to read. Amanda's story, from my perspective, really brings home the sense of powerlessness people experience in a closed culture and the fear and futility of voicing their concerns to the staff, the very staff that are exerting control over their lives. And you'll find other examples and quotes in our guidance that I think really bring it to life in terms of helping us more fully understand and appreciate what the impact of a closed culture is. So if I can have the next slide, please. Okay, so before I hand over to my colleague Jon Ibbitson, I'd like to talk to you lastly about how we can identify services that are at risk of developing a closed culture. So based upon our experience of regulating services, CQC has identified that a service is more likely to develop a closed culture if one or more of 4 inherent risk factors are present, namely, people may be experiencing poor care, there may be weak leadership or management within the service. Another factor is poor skills, experience and training of the staff that are providing people's care, and also a lack of external oversight and scrutiny, which, as we've said, is even more of a factor during the current pandemic. So from a CQC perspective, it's important that we as inspection teams monitor services with these who are presenting these risk factors closely and act to prevent closed cultures developing and embedding. In monitoring these services, our focus must be on paying a particular attention to and giving weight to the views of people using the service and their families and advocates. This information from a CQC point of view may come to us in various ways. These include safeguarding referrals, complaints, information contained on statutory notifications, and speaking to people, their relatives, their advocates, and healthcare professionals, health and social care professionals, actually during our inspection activity. As mentioned earlier, our closed cultures team we are working to develop the tools and resources and training available to our inspection team to enhance our ability to communicate with people on inspection and outside of inspection activity. And our closed cultures team are taking the lead on making those enhancements and improvements in the tools and resources available to us. And this includes a current pilot that's underway within CQC around the use of talking mats. So we'll now turn to look at each of the 4 inherent risk factors individually in a little more detail. Before we do so, I'd just like to say that the risk factors and their accompanying examples that I'm about to discuss with you are all incorporated into the CQC's updated guidance on identifying and responding to closed cultures, which is available on our website. So you can refer back to that to sort of for further information. So if I can have the next slide, please. So the first inherent risk factor is that people may be experiencing poor care in these services. This slide and those that follow it give examples below the heading of the signs that we should look out for that may indicate that this particular risk factor, that the risk may be higher in a particular service. So in terms of the inherent risk factor of people may be experiencing poor care, the signs that the risk may be higher in a given service are that people are highly dependent on staff for their basic needs, that people are less able to speak up for themselves without good support from the service, for example, in learning disability or children's services or care homes for people with dementia. And it can also be the case that that another sign that risk may be higher in a given service is where restricted practices are being used. And also lastly, in healthcare settings, that people stay in that particular service for months or years. So individually, there may be good reasons why these factors are at play, but taken together, these are the signs that indicate to us that the given inherent risk may be higher in that service. If I can have the next slide, please. So the second of the inherent risk factors that we've identified is weak leadership and management. And to look at the signs that this risk may be higher, that these sort of associated risks may be higher in a particular service, these include that there are regular changes in management or managers are not present, and at times the service may run without a manager. And obviously there's a comment here to say that this may be more likely during COVID-19 due to staff being off sick or self-isolating. Managers, another sort of sign could be that managers are frequently absent from the service if they are responsible for two or more sites or teams, and as a result they are rarely present to challenge poor practice or promote good practice. Another sign is that the workforce comprises many members of staff who are either related or friends, causing or allowing cliques to form between particular groups of staff. In addition, there may be a lack of openness or transparency between managers, staff, people using the service, and external professionals and organisations. Another point is that managers do not lead by example, or that staff are not supported or encouraged to raise concerns. Managers may fail to monitor and address issues raised by staff, people who use the service, relatives and visitors to the service. Managers may fail to respond to recommendations of others, for example, professionals, commissioners and regulators. And another sign that a particular risk, this particular risk is more likely in this given service would be where there are differing views between the multidisciplinary team or managers and care staff about how people are being supported. So if I can have the next slide, please. Okay, so the third of the four inherent risk factors that CQC has identified is listed on screen here as being poor skills, experience and training of staff providing care. And the signs that the risk may be higher in a particular service are as follows. So in a service area, this would be the case where there is a high turnover of staff, where there are consistent staff shortages. There is a high use of agency staff within that service, and that those same agency staff do not know the people that they are caring for, perhaps due to a poor induction, lack of training, a lack of time to acquaint themselves with people's needs and preferences. There is also a lack of suitable induction, training, monitoring and supervision of staff at large. There may be no formal or effective processes in place to monitor staff practices. Mandatory training may have lapsed. In the staff induction may be non-existent, or very condensed and not cover the points that staff actually need to be aware of. And there may be no formal system of staff supervision or appraisal in place. During COVID-19, employment checks are not as thorough, giving job applicants who could harm people who use services greater opportunities to be employed. So if the changes that the services made to their recruitment practices during the pandemic mean that those self-same pre-employment checks aren't as thorough, then that obviously increases the risk of a closed culture in that given service. Shift patterns within the service mean that people are always working together and staff are not mixing with other colleagues. So again, this perhaps comes back to the point we made earlier about cliques. So where staff are working with the same colleagues day in, day out, the risk of a close culture developing in that service is that much higher. And also lastly, that staff are working excessively long hours or overtime. So if we can just move on to the final slide, which deals with the fourth of the last of the inherent risk factors that CQC has identified. So this relates to lack of external oversight that we've already touched upon in the presentation, and the signs that the risk may be higher in a particular service are listed on screen. So the service is in an isolated location, resulting in people using the service having limited access to community services and facilities and less opportunities for friends and family to visit. So it's really around the isolation geographically or otherwise of the service. There is a lack of monitoring by outside agencies, and there is limited interaction with outside agencies due to failings on the part of the service to submit mandatory information, such as notifications or safeguarding referrals. In a service of this nature, there may also be few visitors. And during COVID-19, there are restrictions on access to and less external oversight of all services by family, friends, social workers, visiting care professionals, commissioners and CQC, which increases the risk of any closed environment tipping into a closed culture. So at this point, I'd obviously like to thank you for listening to my section of the presentation, and I will now hand over to my colleague Jon Ibbitson, who is going to start by talking to you about the key warning signs that could suggest that a closed culture is developing or has already developed within a service. Thank you.
Hello everyone. So moving over to me, as Carl said, I'm going to talk about the warning signs and what our response should be. So if I could move on to the next slide, please. Okay, so what you'll notice is there's a bit of repetition between the risk factors, the inherent risk factors that Carl's just been talking about, and the warning signs, but it's looking at those risk factors from a slightly different angle, I think, is the key. Because whilst we may already know of cultures that we feel are closed, and we're already dealing with issues in relation to that, what we also know, unfortunately, that a whole number of other services where closed cultures are at risk of developing, and where we need to be vigilant and try and nip that in the bud if we can, so that we can protect people and keep them safe, and make sure that their rights are upheld, really. So clearly CQC has a role in our monitoring and inspection of services. We've got to be alert to the presence of these warning signs, but it's incumbent, I think, on all of us who work in the area. It may be that you are going into services, obviously COVID dependent. It may be that you're going into services and you're seeing things that you think, I'm a bit worried about that, I'm a bit concerned, what should I do about that? It might be that you are commissioning services from from people, and you get information that makes you concerned, or it may be that you work in a service, or you engage with another service and you think, right, I'm a bit worried that there might be a bit of a closed culture developing here. So we'll just spend some time thinking about what that means. Now, it doesn't, I should say up front that if these warning signs are present, it doesn't mean for definite that there is a closed culture, but I would suggest there would definitely be a need to look into it in a bit more detail and to try and rule that out. Equally, there may be a service that does have a closed culture but doesn't display these warning signs, and we need to be aware of that as well, which makes it even more complicated, I think. Okay, so if we look firstly at leadership and management, one of the key warning signs is about senior staff. Do they know what's happening, and are they present in the service? Now, presence in a service doesn't necessarily mean that senior staff are in an office with the door shut with the do not disturb sign on it. And we've all seen that, and we've all experienced that, I'm sure. It's about what those senior staff do while they're at the service. Do they interact with people who are using that service, or are they preoccupied with management tasks which take them away from people using the service and the staff? You know, have they got eyes and ears in the place that might allow them to pick things up if they shouldn't be happening? Is there feedback gathered from people who use services regularly, and is that used to improve the service? And really fundamentally, are senior managers a regular presence in that service? Now, I know in some instances COVID might make that difficult, or might make that be done in a different way, but it's about the level of presence in the service is a key issue. And thirdly, really in relation to leadership and management, where concerns are raised, are they recognised? Are they acted upon? Or are they played down, or are they ignored? Or might the response be, well, that's just how we do it here, or we don't do it like that here. You know, that's how we've always done it. Those kind of comments, particularly from a senior member of staff, should really raise some alarm bells for us and make us think more carefully about what might be happening, I think. Okay, so if we could move on to the next slide, please. So people's experiences. So in terms of warning signs, we should really be thinking about, are people isolated from each other? So people using the service, are there a high proportion of those who don't interact with each other, and what is the reason for that? There may be legitimate reasons for that. It may be about safeguarding, it may be about keeping people safe, but it might be that there doesn't appear to be any reasonable explanation for why that might be happening. Are people comfortable with staff? So how do people react to staff in staff's presence? What can people tell us about the staff that support them? What's their body language like around staff? How do people behave towards each other? Can be a key factor. And how does staff behave towards people using the service? You would be surprised, I think, and I'm sure Carl would agree with me on this, the number of inspections that I've done or that I'm aware of where staff have behaved in such a way on the inspection in front of the regulator that make you think that's really not appropriate and that's really poor practice. What therefore might be happening when there's nobody in this service, no external professionals, no regulators within this service? What else could be happening? And that's something I think we need to think about quite clearly. Okay, what else on that one? Okay, so the other thing to look at is how is there an attempt in a service that you're aware of to try and control people's behaviour? We'll come on to restraint and seclusion in a minute, but there can sometimes be some very low level kind of punitive measures that are taken when people, for example, exhibit behaviours that might be challenging to themselves or others. How does the service deal with that? You know, do they remove privileges from people if that happens? You know, are people confined to their own rooms, for example, for short periods of time on the basis that that's going to protect them or protect other people? But actually, where does that tip into punishing someone for exhibiting a behaviour that might actually be part of a health condition, but might also be a reaction to a service they are in that's not actually meeting their needs properly? So we need to just think really carefully about that sort of thing as well. And sometimes you can see things buried in daily records, for example, You might read it and think, that seems a bit excessive. So we need to be mindful of that sort of thing happening too. Okay, if we can move on to the next slide, please. So staff skills and experiences. Does staff know people's needs? Do they know their wishes? Do they know people's history? Has some time been taken to find out what's important to people? Do staff actually know what they're doing? Have they had the training that's needed to work with particular individuals to meet their needs? For example, have they had any kind of training or awareness around supporting people with autism or positive behaviour support or anything like that? Is there any kind of emphasis on creating a communicative environment for people who use the service? So do they use personalised communication aids, that sort of thing? But it's not just that. Do services encourage and make use of independent advocates, for example, or is everything kept very in-house? And is there a reluctance to let other people in to see what's happening? So the use of independent advocacy is a really positive thing, and you'd want to see that in any service really. But if it seems to be an active unwillingness to engage with that sort of support, then that's a key issue. And really fundamentally, are staff attending to people's very basic needs, or are they helping people to do so to themselves where they're able to? If they're not, then that can be a sign of a negative closed culture developing. Okay, next slide, please. Okay, so this is a key one really, and I think the difficulty with this one is it's not always obvious where restrictions are happening, but are there imposed restrictions in place? So, and if there are these reviewed to check whether they're legitimate? Are they the least restrictive option, and are they proportionate? Restriction is sometimes necessary, but it's got to be regularly reviewed. It has to be for a demonstrable reason. Safety, for example, and is it the least restrictive option? The service themselves should be asking that question, but if they're not, then as external professionals, if that is your role, then we need to, and we also need to be thinking about that in terms of a warning sign for a closed culture. And if there are restrictions in place, are they proportionate to the individual and to the situation that they find themselves in, or are they blanket restrictions? Is there a blanket restriction such as, well, you can't go out after a certain time, it's for your safety? Well, actually, is there any reason why that would be the case? We can't have visitors in at the moment, it's not safe. Those sorts of things need to be looked at. And clearly, when we're talking about restrictions, as we all know, I'm sure, we need to be looking at the Mental Capacity Act and the deprivation of liberty safeguards. We really need to be seeing that legislation adhered to, because that legislation is what is designed to protect people from infringements on their liberty where it's not legally viable, and in relation to people's capacity or otherwise to make decisions for themselves. Okay, and we talked about one of the warning signs earlier being, is there segregation between people? Do people mix? That can be used as a restriction, and a quite disproportionate restriction in some situations. Okay, next slide. So the use of restraint. So is there high or increasing use of restraint? Seclusion, segregation, as I mentioned earlier. It might be quite difficult for us to know about that, because currently there's no mechanism for notifying use of restraint to CQC, for example, unless the restraint triggers another notification, such as a serious injury or a safeguarding alert. But we as CQC, and you as other professionals or people working in engaging with services, might have other intelligence about the level of restraint, the level of seclusion, the level of segregation. And if those appear to be on the increase, that is a really key warning sign of a closed culture developing. And if it isn't a warning sign of a closed culture developing, it is a warning sign that something within that service is not necessarily working as it should be. Okay, so oops, sorry, I lost my screen there. Okay, it's come back. So if you could move to the next slide for me, please. So the physical environment, there can be something very telling about the sheer state of a physical environment and what that means for the thought behind that, what that means for the empathy of the people living there. You know, what does that indicate about the attitude of the people who are running that service? So is the environment well maintained? Is it clean? Is it sanitary? Have people been encouraged to personalise their own rooms? Would you be prepared to live there, or for a loved one to live there? You know, what I would say though, as a bit of a caution there, is that unhealthy cultures can also develop where the physical environment of the service is good. It's not to say one equals the other. It's just to be aware of this as a potential warning sign. The other thing to consider is what's the layout of the service like? Does it have lots of small rooms or rooms leading off rooms, areas that could pose a greater risk of abuse, for example, going unobserved? Those are all things to think about when we're thinking about whether a close culture is developing. Okay, next slide, please. So a key element of this spotting the warning signs and responding to the warning signs of a closed culture is around external oversight. Now that can be by us, CQC as the regulator, that could be by the CCG, it could be by the local authority, it could be oversight by a provider of one of the services they're running. And it's really about us thinking about, when we get that information in, when we get that intelligence in, what is that telling us about service? So there's some key things really that we need to be looking at in relation to closed culture. So is there a high or an increasing number of safeguarding incidents, complaints or other notifications? And these can be especially concerning if they involve things like inappropriate behaviour by staff towards people using a service, unexplained injuries, even when safeguarding investigations don't find any abuse, an increase in incidents where people using a service can be violent towards staff. That can be a real indicator of a closed culture developing. Complaints by people using the service, their family, their friends, maybe their advocates, including those that are withdrawn subsequently. You know, we need to be thinking about why that might be the case. Complaints that family members or others such as advocates are being prevented from visiting a service or receive a fairly hostile response from the service when they do so. Complaints that family members or visiting professionals are not enabled to see someone in private. So, you know, there's a staff member present at all times. Why would that need to be? You know, what would be the logical, justifiable reason for doing that? So that can be a real key warning sign for a closed culture developing. The key thing with this is when we're looking at external oversight and we're looking at the intelligence that we hold, you know, this will not be news to anyone, but it's come up time and time again. The key thing really is looking at those bits of intelligence, not in isolation, but in terms of, does that show a pattern? Is there a pattern of abuse? Is there a pattern of unexplained injuries? Has this happened over a short period of time? How long has this been going on for? All this has come about in relation to one service, for example. So we should all, as we know, be wary of treating each incident on its own without linking it to the other bits of intelligence that we have. And one of the real key things to bear in mind is, in terms of doing something about this, sometimes there is a tendency to think, well, this has already been reported, I don't need to report it again, or we already know things are happening at this service. It's really, really important for all of us, where we're made aware of something that is a concern, that we raise it, that we report it, because if everyone thinks everyone else is doing it, or if everyone thinks that we already know all this stuff about this service, then it doesn't help us to build up that pattern of concerns over a period of time. Okay, next slide, please. Okay, so it's important to say, I think, that the presence of one or more inherent risk factors is not proof that there's an abusive or a punitive culture, or the presence of one or more of those warning signs doesn't prove that there's an abusive or punitive culture, but it could be a sign that there's an increased chance of one developing. And even a really good service can deteriorate, and a closed culture can develop if the risk factors are there, if the warning signs are there, and if action isn't taken quickly enough. It can really deteriorate quite alarmingly quickly if we're not if we're not keeping abreast of it and trying to do something about it. And some of the really key considerations for us to think about around responding to closed cultures are, can people self-advocate? And if they can't, is there anyone who can advocate for them? Is there a high inherent risk? Carl went through the inherent risk factors. If there's a high risk of those, and are there any warning signs? Now, the real key concern for a closed culture would be if people can't self-advocate, if there's high inherent risk, and there are warning signs. That's really a culture that we need to get into and need to be doing something about. As I've said, the real key thing is if you're concerned, take action and report those concerns, to whatever reporting mechanisms you have within your organisation. But the real key thing, as we all know, is that organisations share information with each other. And as the regulator, it's really crucial that you share those concerns with CQC, but by whatever mechanism is agreed that should happen, because closed cultures can't be tackled unless concerns are shared and they're acted upon. Okay, next slide. Okay, so who can I contact? Well, you can call our National Customer Services Centre, and the number is there on the presentation. You can contact us at inquiries@cqc.org.uk to really share those concerns and make sure that the information that you've got is passed on to us as the regulator, so we can see if there's a pattern building up and see if there's anything we need to take any action on. Next slide, please. So just to finish, really, just to repeat what was said earlier, the question, I can see there's been a lot of questions posted. The questions and comments are being collated. The organisers will coordinate a response to those. We've got, you'll get this presentation, and I think it'll be explained to you at some point how you might get that. This is really just kind of the wrap up bit, where it's a plea really from us to stay connected with CQC if you can, and stay involved and to keep abreast of what's going on. So you can sign up to receive our provider bulletin, and there's a link for how you would do that at the top there. If you're someone who uses social media and Twitter in particular, you can follow CQC on Twitter if you're minded to do so. We've got a digital platform where you can give feedback. There's surveys on themes and the developing strategy within CQC, and there's a link for how you can access that there, the third point down. Podcasts, there's podcasts you can also listen to, so wherever you usually listen to podcasts, on Spotify for example, if you search for CQC Connect, you'll see those come up. And lastly, there are blogs that are completed regularly by key people within the Commission. There's the link for how you would access those blogs. Okay, so next slide, which I think is the final one. And that was it really. So just as you'll see there, there's our names again, should she need or want them. I don't know why they're at the end as well as the beginning, but hey ho, might as well stick them on there twice. We've got our website address there, cqc.org.uk, and again that's a repeat of the main kind of inquiries email address that you can use. That's it really. Just to say, in case you're wondering, I'm not breaking lockdown and sat on a beach in Tenerife, I can assure you. It's my background that I struggled to change as I joined the course, so that just to let you know why that's there in the background. So that's it. I'll hand over, I think, unless I'm mistaken, back now to Rachel.
That's great. I just wanted to say a really big thank you to Jon and Carl for that presentation. It was really thought-provoking, and I think especially at the moment with the COVID restrictions, as they highlighted, we all need to be thinking about what are those warning signs and what are those risks of closed cultures. So I think that was a really helpful presentation, and all those resources at the end as well. As Jon said, there was a lot of questions cropping up throughout the presentation. We will be collating those questions and sharing with you afterwards the answers to those questions. We've also got the link to the recording of this webinar and the slides, so that will all be coming out to you sort of in a few days' time after this session, so look out for that. If you could just use the link to the evaluation form, which should be in the chat now, and just take a couple of minutes to give us some feedback. It's really helpful that we get feedback on these sessions, so please do complete that. And just a big thank you to all of you for joining us this afternoon to think about closed cultures. I hope you found it really useful, and I hope you'll take what you've learned back to your colleagues and your teams to kind of talk about that further. So that's the end of our session today. Thanks, everyone. Bye-bye.
Thank you.